Treatments for depression. The revolution has arrived. My name is Christoph Correll. I'm professor of psychiatry at the Zucker School of Medicine at Hofstra Northwell in New York, and I'm also professor and chair of the Department of Child and Adolescent Psychiatry at the Charité in Berlin. And I'm joined by a good friend and colleague of mine, an expert in psychopharmacology, Roger McIntyre. Roger, welcome to Novel Treatments for Depression. The revolution has arrived.
It has arrived. Christoph, great to be with you. Always fun to do this and looking forward to this conversation. And thanks to our colleagues for joining us.
Excellent. So we've had a drought of innovation, haven't we, in depression? Basically, many decades where we've had only neurobiologic or biogenic amines like serotonin, for example, especially though, then noradrenaline and some dopaminergic treatments. But what we don't have is really innovation for 50, 60 years. There has been a refinement, less side effects, maybe combination now with other agents like antipsychotics, as we call them. But in terms of antidepressants, we've had a drought. But now there is something new. Ketamine, non-racemic, and then we have esketamine as NMDA modulators. We will talk about GABA modulators. We'll talk about also treatments that are in the 5-HT2A realm, which is the psychedelics. So a sprouting of novelty in the last decade or so, and it has reached patients by now, hasn't it?
It truly has. In such a great way to start, Christoph. As you know, the 1950s was a transformative time in psychiatry. It was during that remarkable decade that psychiatry and patients and families were first introduced to conventional antidepressants, conventional antipsychotics, benzodiazepines, some of the anticonvulsants, and lithium certainly took off in the 1950s. But you're right. Despite the fact that being a prelude to 7 subsequent decades of pharmacologic refinement, I don't think the word transformation can be used again since the 1950s. We need to have transformation 2.0. And I think that what we're now entering, in my view, is we're entering into a new zeitgeist in psychopharmacology and psychiatry, which is very hopeful, wherein we can start to think about treatments that are mechanistically informed. Some might say, well, who cares? How does it help our patients? Well, it could be transformative in helping them in a way that the drugs work better, they work faster, more difficult to treat situation, more dimensions that are really hard to treat, like anhedonia, maybe even disease modifying. Wouldn't that be awesome? We can't make that claim for any therapeutic. So these are unique times, and I think we are entering into a more or maybe a less uninformed or more informed time, whatever your vantage point is.
Great. So let's walk us through the brain. What happens when ketamine or esketamine are given?
Well, it's interesting. I think it really begins with just a quick kind of quick version of the pathophysiology model of depression and other stress-related diseases. And that is that we have a working hypothesis, which is supported by a triangulation of evidence that the brain in people who are living with depression and other related conditions is impaired at multiple levels, including molecular and cellular processes related to plasticity and related to brain trophic activity. And whenever you talk plasticity and trophic activity, well, you're talking about glutamate. It plays such an integral role to these molecular and cellular processes. And so from that set of observations, a separate observation was made that ketamine, first synthesized in 1962 by Calvin Stevens in Detroit, approved as an anesthetic, was known to be an NMDA, that is a glutamate receptor modulator. So sometimes these observations, which can occur, in different labs, people start having this kind of light bulb moment. Hey, if this treatment is affecting glutamate, and glutamate seems to have gone awry in depression, why don't we repurpose ketamine and its enantiomer, esketamine, as a treatment for depression? So it's just kind of axiomatic, it's kind of self-evident thinking.
Excellent. So basically, we're trying in a fast way to shake the brain and get it out of some default network or some desert-like constitution, and then it basically has a different spin, not for everyone, but for people who couldn't respond to an SSRI or SNRI or other treatments. Is that right?
It's such a good point, because so often we have patients who come to us and they have in their chart, they have treatment-resistant depression. Well, it turns out they don't have treatment-resistant depression. They have SSRI-resistant depression. And what we need is a different mechanism. I've had many hundreds of patients now who've been referred for so-called treatment-resistant depression who take ketamine or S-ketamine and they're back to work. So we wouldn't call a pneumonia that's not responding to penicillin, but responds to amoxicillin. We wouldn't call that treatment-resistant pneumonia. They're on the wrong drug. And I don't think that metaphor is not appropriate. I think that's what's going on. But again, it's about different mechanisms. And what's interesting about the glutamatergic modulators, which don't just end with ketamine, S-ketamine, there's others we're going to talk about, is that they are targeting a neurotransmitter system that's so highly implicated in the pathophysiology of major depression.
So let's look at some of the data. This is one of the first meta-analyses we did of ketamine, and it was just amazing to see that after 240 minutes, these people had been sick for many, many months. They already had an effect size that is quite respectable, medium effect sizes. And within the next 3 to 4 days, it went to almost 1, effect sizes being usually 0.4 in medicine. And it lasted up to 8 days. Now, this is obviously an IV treatment, and you've done thousands in your clinic, but that's not necessarily something that many people can receive. That's why then J&J tried to formulate that in a different way. Tell us about S-ketamine.
So S-ketamine is the enantiomer. Just a reminder that ketamine is a racemic mixture. It has 2 different mirror image moieties, and S-ketamine is a enantiomer, and it can be pharmacologically produced and has a very different, as you know, Christoph, pharmacodynamic and pharmacokinetic. Maybe details for another day, but one detail I will highlight is that its affinity for the NMDA receptor relative to its racemic ketamine is on the order of 3 to 5-fold greater. So that caught the eye of many of us. Maybe we could use a lower dose of it, etc. Now, S-ketamine has, just like ketamine, been evaluated in major depressive disorder. That's been very difficult to treat, and also evaluated in patients with depression who are at imminent risk of harm. And the FDA approved this medication for TRD, treatment-resistant depression, March of 2019. In August 2020, it was approved for patients with MDD at imminent risk of harm. Now, updates have happened. It was initially approved as an adjunct with co-commenced antidepressants, but also now it's approved as a monotherapy in TRD. And just like ketamine, it is known to trigger a molecular cascade of events that consequences with an increase in the translation of proteins in the brain, critical to plasticity, critical to trophic activity. And just a kind of a neuroscience reminder for all of our colleagues, when we have 2 neurons that are forming connections together, that's a plasticity process. Neurons that fire together wire together. And in the language of neuroscience, it's called long-term potentiation. And around the brain, there's problems with long-term potentiation throughout the entire brain that we call scaling. And the hypothesis is that S-ketamine, ketamine correct long-term potentiation locally, that is long-term potentiation, but also throughout the brain, which we call scaling. So it's correcting the plasticity process.
And communication. As we need to communicate with other people to feel good, our neurons and our neural networks also need to communicate.
That's right.
Now, the S-ketamine study I found quite interesting because it highlights again how difficult drug development is and has been since, because when we look at the shape of the curve, people who knew, oh, this is a rapid acting antidepressant, had this dip after 2 days. And when we look at the responder rates, it's quite astonishing that people who had been on average in these studies 1 to 2 years ill in the current episode, 50% just being switched to yet another SSRI that hadn't worked before, either with placebo or with S-ketamine. But when placebo was added, 50% had a 50% or greater reduction in symptoms, and a third after just 4 weeks were in remission. Isn't that's heartbreaking for other drugs that will never sustain such an onslaught of effect by just expectation?
Yeah, it's so true. And I think it's important to highlight for colleagues that, this is a treatment that's not given every day. It's given, in the first month, it's given twice a week. Then the second month, it's, once a week. And then it's, once or twice a week there. It depends on the patient thereafter. So this is a very different paradigm. They're not getting it every day. And the second part is there are long-term data out to 6 years now with people who have received S-ketamine in a very closely monitored protocol in depression, showing, first of all, it's safe, it's well tolerated. We're not seeing problems with cognitive impairment. We're not seeing problems with respect to cardiac or hepatic or kidney or bladder injury. and it's sustaining the effect in very difficult to treat depression. So it's a fast acting, and it seems to last that benefit in people who take it.
So this is intranasal, but it also had been controlled now and compared against another active treatment, and that's quetiapine. How did that work?
Interesting study, such an important study. I've often said I wasn't part of this study. I've done some post hoc analysis of the data set. But this is, to me, one of those studies that comes out once every decade that has direct implications for clinical practice. In clinicians who see patients where the patients had an inadequate response to an antidepressant are faced with the clinical decision almost daily: do I add an atypical antipsychotic, or do I switch to something else? If so, what? So esketamine compared to quetiapine XR, the primary question is, what's the remission rate at week 8? Turns out in this difficult to treat population, esketamine has higher remission rates when adjunctively administered in this population when compared to those taking quetiapine XR. But the other part, which to me is no less relevant, is the 32-week follow-up, or the 42-week outcome, where we're looking at relapses in people who achieve remission 8 weeks. And the relapse rate was considerably lower in people taking esketamine who remitted at week 8. So we have this efficacy advantage, and guess what? There were more dropouts in quetiapine, and also, no surprise, more weight gain and metabolic problems in the quetiapine arm. So I think it was not just an efficacy story, but a tolerability and acceptability story that was also coming out. So I think it has implications for how we algorithmically select and sequence our treatments.
Yeah, so this is what you said already in terms of the long-term outcome here, and also the safety. So in a way, it's very rarely done that there's an active controlled trial that is not just for assay sensitivity, but here it was really head-to-head, trying to show against a common comparator that in some countries is used quite a bit for difficult to treat depression. And here esketamine really had an edge, which is interesting and validates, I think, the whole idea of the NMDA antagonism that has some AMPA agonism at its core in order to help rapid-acting antidepressant capacity. But the intranasal part and having to monitor the patient for 2 hours because there could be high blood pressure and crises is a limitation at the moment. Also the intermittent treatment, not everybody really wraps their head around it. So what about an oral formulation? That has recently been studied too, correct? Not yet approved.
That's correct. And I think just a comment, maybe to back up a bit, there are different ways we can deliver ketamine, or, and for example, we've talked about IV, but it is available orally. There's sublingual, there's subcutaneous, there's intramuscular. And I think the short maybe narrative would be that there are differences with respect to the levels of evidence. Most of the evidence is with IV, of the racemic ketamine. We're not talking about esketamine intranasal, the J&J product. But there are obviously efforts to find easier ways to take it. Obviously, oral's easier. The wraparound is, in other words, the amount of infrastructure is less, et cetera. And even maybe the potential for taking it home. That's a longer story. But to make it easier to access is the opportunity. In short, oral ketamine has a little bit unpredictable bioavailability. We always say it's around 20%. Yeah, but it's quite variable. There are evidence, though, to show that it can be safe and effective in TRD. We've used it for many years, both sublingual and oral, off-label, ketamine in TRD. It can help some patients, no question about that. It clearly is easier to use. But there is a unpredictability to the kinetic, not just between people, but even within individuals.
Okay, that's very important to know. So we are not sure how much that delivery system is actually good enough. But we've had another approval in addition to esketamine that again has to do with the NMDA receptor system, and that is dextromethorphan plus bupropion. Now, dextromethorphan is actually a cough syrup and has been tried also with quinidine. And why is there always something added to it? What's going on there?
So interesting. What a history. Dextromethorphan, goes way back to the 1940s and 50s. This was derived from a medication called Resorphan, and dextromethorphan was first approved as an antitussive, a cough medicine in 1958 by the FDA. This is a medicine that's got such an interesting mechanism. Not only is it an uncompetitive NMDA antagonist, but it's also a sigma-1 modulator. And the sigma-1 receptor modulates not just dopamine and norepinephrine, but modulates glutamate, and guess what else? The inflammatory system. So there's a target here and a reason to believe that this drug is not just only engaging glutamate, but other neurotransmitters, including not limited to the catecholamines like dopamine, but also the immune inflammatory system. So very interesting. And there's now bupropion was added for a very simple reason. Dextrorphan, when taken orally, is rapidly and extensively metabolized. So its half-life is very short, around 7 hours. The bioavailability is in most assays less than 10%. That's not enough to have enough what we call target engagement. The drug has to hang around, just like anything else in life. You have to hang around for a period of time and make an impact. So it wasn't hanging around long enough. So one way you can address that issue is you just add bupropion. It inhibits the CYP2D6 isoenzyme, which is the enzyme that breaks down dextromethorphan. Hence, you increase the half-life to 22 hours. You increase the bioavailability, and abracadabra, you've got yourself a viable product. So this really is a dextromethorphan story rather than a dextromethorphan bupropion. Bupropion is more kinetically there rather than pharmacodynamically there.
Yeah, and that had been tried before with quinidine. And there was a deuterated form of dextromethorphan, but it didn't really work well for agitation and aggression. But here we have something that works for depression, but it didn't work for treatment-resistant depression or difficult to treat. Tell us a little bit about that.
Yeah, it's interesting. I mean, this is a drug that being the combination dextromethorphan bupropion that is FDA approved as an oral rapid-acting antidepressant in major depressive disorder. There was a study that was done in adults with TRD where it did not beat placebo in that paradigm. As is always the case, Christoph, you and I have had these discussions many times, and other colleagues of ours, where we kind of do postmortems, if you will, for lack of a better way of saying it. And you go back and you kind of try to figure out what could have gone wrong. There were a couple of methodologic aspects about how the trial was designed, which would, I guess, inform the next study. In my own opinion, this is me speaking just as, a person with a view. I don't think that the last word has been said about this yet. I think there was some methodologic aspects there, but it did not beat placebo. And now we should also mention this medication is also been evaluated in agitation and Alzheimer's disease, and also it's being looked at now in smoking cessation, where preliminary work shows it works better than bupropion on its own.
Yeah, so here's the study that compared it against bupropion on its own, just to say that, okay, this is BID dosing, 110, that's 220. It's not enough as an antidepressant that would carry the weight. It's really the dextromethorphan, the 45 milligrams, that's also given twice a day in order to give it some edge. Now, some of our viewers and listeners will not have dextromethorphan bupropion available to them as a combination treatment, but could they try it out where they live?
Well, there's two answers. The first answer is I guess in life you can do whatever you want. But I think that, for me, and Christoph, this is not going to surprise you. I've actually, over my career, I've always tried to maintain a certain pragmatic position, but also details matter. And there were 12 studies done by the sponsor to try to get the kinetic just right between bupropion and dextromethorphan. And consequent to that, I do think that obviously we want the proprietary product, but someone's going to say, well, it's not available. Well, I just did a study with my colleague, Angela Kwan. We just published it. We looked at the FDA adverse event reporting system. And what we did find was interesting is that we could find no reports of misuse of dextromethorphan bupropion. Full stop. No misuse of it. Because dextromethorphan could be a drug of misuse. But we found no cases reported or proportionally higher reported to the FDA with dextromethorphan bupropion. But with dextromethorphan, we did. And keep in mind that when people are misusing dextromethorphan, it's not dextromethorphan that they're misusing the metabolite called dextrorphan. And so when people are mixing and matching different doses of dextromethorphan and bupropion, well, you're probably, you're going to see more dextrorphan. And so that makes me a little uncomfortable. So again, safety first. I think these are decisions people have to make individually, but I haven't been as comfortable with it.
Okay, so you wouldn't advise anyone to get whatever is in their country of dextromethorphan and then add bupropion, and hopefully we'll get more of this medication available to us. It's pretty well tolerated. I think that's not an issue, correct?
It's extremely well tolerated, and the dropout rate due to side effects, the rate of severe or serious side effects is very low. Some patients can get dizziness on it, but a GI but they tend to be transient, mild. Reason for discontinuation is very low. It's extremely well tolerated. And I think the other part about that too, Christoph, is that look, we often think about this. If you were designing a new antidepressant, what feature would you want in it? Well, just ask patients. They want things to work rapidly. Can you imagine going to the emergency room with a migraine and the staff say, "Oh, here's the treatment for your migraine. It'll take 4 to 6 weeks to work." I mean, only psychiatry thinks that way. It says this is crazy. So, I mean, clearly people want to stop suffering. And so the fact that it works so rapidly within the first week, recognized by the FDA, I think is a real feature about the treatment that has been, I think, really, no surprise, affects the attitudes that people have about this medication.
Yeah, that's just, since we didn't really touch upon the side effects of esketamine, bring that back in, because there are some things that are unusual, like dissociation. How long does it last? Is it really an issue? Because we'll talk about side effects also of the psychedelics in a minute.
Yeah, good point. We don't see dissociation with dextromethorphan, bupropion. That's good news. You're right. Esketamine dissociation can be seen. The rate of, the severity of, and the duration it lasts decreases with each subsequent treatment. So it can be seen. I should also mention that dissociation is a side effect. It is a treatment emergent adverse event. It is not required for esketamine, ketamine to work. And that's been a misunderstanding in the field. Some people even have clinics where they give people ketamine or esketamine so that they start to dissociate because they think it's necessary to engage in psychotherapy, so-called ketamine-associated therapy. That is not true. You're harming the patient. This should stop. So you don't need dissociation. The other side effect, I think, was more of a safety concern, Christoph. Blood pressure elevation. It's usually transient. It's not. It can be usually treated symptomatically or with medication. Gastrointestinal nausea. And some patients can get somnolence or a kind of a sedation from it. That's why there's a REMS. You have to watch patients for 2 hours who take esketamine. Ketamine does not have an indication, so it doesn't have a REMS. But we recommend in our guidelines on this that patients should also be monitored for 2 hours and taken home by a loved one or some trusted person after the end of the session.
Makes sense. So let's look at yet another mechanism of action for depression. And that came a little bit as a surprise at first, at least to me, a neurosteroid. Now, when you link that then to the first indication, postpartum depression, it's somehow connected. But walk us about this zuranolone, brexanolone story.
This is such a great story. And for those maybe less familiar, we've known forever that there are neurosteroids in the brain. And the street light just wasn't shining on them, quite frankly. We've been shining the light on almighty serotonin for 7 decades. But we've had these neurosteroids in the brain, and they have very important physiologic roles. And one of these is one called allopregnanolone. And allopregnanolone has been known for a long, long time. It's been known to engage, among other things, GABA systems. And this was observed in studies going back decades, quite frankly. And then somebody had a great insight. Somebody said, well, is there a situation wherein we could see a precipitous change in allopregnanolone levels? And the answer is yes, you can, because the derivation of allopregnanolone goes back to a sex steroid. It has a similar kind of structure. So women who go through pregnancy at parturition, obviously it's a very precipitous change in their neuroendocrine milieu. And one of many changes that occurs is the rapid reduction in progesterone, the rapid reduction in some of these steroids. And that has been hypothesized to be playing a role in the pathophysiology of postpartum depression. I don't think the story is only that, but we know that these neurosteroids affect GABA systems. Some might say, well, doesn't benzodiazepines? They're not antidepressant. Well, that's true. But what's different is neurosteroids actually target not just the synaptic GABA, which is what benzos do, but also the GABA outside the synapse, which is, again, location, location, location. And so what we have is an antidepressant. They're called positive allosteric modulators of the GABA receptor. And so zuranolone, in its IV formulation, is a natural mimetic of this naturally occurring allopregnanolone. And there's also an oral zuranolone, which is a synthetic mimic of this, effectively, this neurosteroid that has rapid antidepressant effects. So it's part of the GABA glutamate balance, excitation, inhibition. like a seesaw to keep plasticity and keep trophic activities in play.
That's so interesting. But the GABA receptor obviously has multiple subunits. So does it engage in the same subunit as the benzodiazepine? Does it make people sleepy, or what's the story there?
What a great point. And the answer is no. And this is where details matter. There are subunits on the GABA, just like there are on the glutamate system. And there are differences with respect to their binding, not just location, but binding on the subunit, and also the effect they have on the GABA receptor expression. Consequently, you don't have the abuse, you don't have the dependence that we are more used to with benzodiazepines, and you don't see the same receptor downregulation. And to your point, you don't see the same effects with respect to, as you mentioned, on sedation and sleep.
Yeah, so there have been meta-analyses and studies. Obviously, brexanolone is an IV treatment for 60 hours for very severely debilitated women who have postpartum depression, can't take care of themselves or the baby. So you, boom, need to get them back into life, and that there can be bonding with the baby. And as you mentioned, zuranolone is the orally taken medication. But it worked, again, for postpartum depression. It didn't work as well for the regular depression, has not been approved for it. Is that the right decision by the FDA? Should it be pursued further? Sage has not announced whether they are going forward. What's your story there?
Well, look, I think that, with respect to folks who may not be as familiar, the drug is approved for postpartum depression. There was an effort to have an FDA indication also in major depressive disorder that's not postpartum. And this would be a treatment that would be a PRN. You take it as you need it, so to speak, antidepressant. It's part of a larger effort to identify therapeutics that are mechanistically informed, that are affecting the brain in such a way that they're having effects long after the drug is no longer there. So I think that this is a paradigm we have to keep tackling. There's differences of opinion on many things in life. The FDA landed on they're not convinced that the antidepressant effects have been proven, and et cetera. I had a slightly maybe more charitable look at the interpretation of the data, but look, it is what it is. I do think, however, that going back to the drawing board is not a bad idea. There were aspects about placebo response, aspects about how the trials were designed, but I don't think this is a paradigm that's leaving. Patients have said enough's enough. We want treatments that work rapidly. We want treatments we don't need to take every day. And they deserve that. And we have mechanistic reasons to believe we can do it. So I wouldn't throw that baby out with the bathwater just yet.
Yeah, so what's been shown clearly is it can speed up the effect. So one could say, whenever you start an SSRI, why don't you give zuranolone with it? Because people may not need to go to the unit and be hospitalized. They might be able to get back to work faster.
Right.
But the effect seems to wean off. And then also this event-driven treatment is a little bit of a problem, because if you wait for full depression to evolve, we might actually trigger a next depressive event and make people more vulnerable. So maybe these treatments should be not event-driven, but rather timed-driven, so that every 3 months or every 2 months you get another boost for those patients that might need it. But again, I think more grist for the mill, something we need to study in the future in order to get there. But let's go to our last chapter before we just briefly rattle through some of the ongoing developments, because that is also quite exciting. We've unleashed drugs of abuse and bring them back into the brain for some medicinal use. So what about the psychedelic story?
It's kind of a rejuvenated story. Obviously, the story began many years ago. Psychedelic, meaning mind manifesting, two Greek words that were a portmanteau. And really right now it's a large tent. It does encompass ketamine, which is dissociative. It does encompass MDMA, the so-called empathogen, but also the so-called serotonergic psychedelics, which is what people usually talk about with psychedelics. And so I'm going to refer to that, if you will. And so we have the so-called tryptamines like psilocybin and DMT, ergolines like LSD, phenethylamines like mescaline. And this has really taken off. But to be very clear, the rigorous data, as you know, Christoph, is mostly short-term. And short-term controlled trial evidence has really been delimited to treatment-resistant depression, major depressive disorder, and for alcohol use disorder for two entities really only, that being psilocybin and LSD. So much of this is sort of hype. There's a lot of excitement. We're all very hopeful, but the foundation and the evidence standards should be no less for these than any other treatment. And in keeping with that, the data, the corpus of data, the body of data is largely short-term, and really with two of them, LSD, psilocybin, and largely in depression and in substance use.
There's also been data in PTSD, but the FDA ruling on that, I think, informs what we have to discuss here, and that is so-called functional unblinding, meaning, for those that don't know the term, that the side effects that come with a drug that might be so much stronger and very specific to a drug, different than what would usually happen with expectation or placebo, could lead people to know that they're on a drug. And then when they expect this to happen, especially when they had trip experience in the past, they might actually have a nocebo effect when they don't get a trip and say, damn it, I get the dirty end of the stick again. Not only am I depressed, I don't get the real deal. And that might really aggrandize the difference between the two treatments, so that the FDA had some papers released how you should study this, so that there's a pseudo placebo or low dose that have some side effects but not the full effect. I think we're learning how to apply this. And you should also talk briefly about the fact that this is psychotherapy assisted, or basically you're just keeping people safe in the beginning. Do we need psychotherapy? What about psilocybin alone? Tell us about that paradigm, which is really very different. But maybe before you do that, on the slide, just what happens in the brain. Is it again BDNF, or is it a different story?
Well, it's really interesting because there are overlaps. There's no question that psychedelics like psilocybin do affect the glutamatergic system. 5-HT2A is the receptor that psilocybin has very high affinity for. So does LSD. They're not selective. These are psychedelics that target many other receptor systems. And so by targeting 5-HT2A, by definition, you're targeting glutamate because it's so populated on glutamatergic neurons, and 5-HT2A is excitatory. We also know that it has effects directly on BDNF. For an example, psilocybin and ketamine have a very high affinity for the BDNF receptor called the TrkB receptor, where they behave as an allosteric modulator. So there's a direct effect on these systems implicated in plasticity and trophic activity. I think to this point, this is you touched on a couple of conceptual implementation, interpretability, generalizability aspects, Christoph, that being the essentiality of psychotherapy. One aspect I've been writing about is how essential is the trip? And the trip may or may not be essential. Maybe it's essential for some people. We don't know. But this field has really, in some cases, prematurely concluded that the trip is absolutely essential. That's still a testable hypothesis, frankly. And there are, in fact, efforts underway to develop psychedelics that don't have the trip. And so that's an interesting campaign as well.
Called neuroplastogens instead of psychoneuroplastogens.
Correct. So I think that for me right now, I think that these are critical. And you pointed out unblinding, you're right. There's also a robust expectancy here, because the testimonials on Netflix and on TikTok and that people are taking, and some very persuasive people, the so-called Michael Pollan effect, has had really quite an expectancy in these treatments. The people have got ramped up expectancy. And as you mentioned, they're unblinding that's taking place. But again, I don't think that the fact that you can guess what you're on and guess with a high level of certainty, that doesn't necessarily negate or invalidate, but it's something we have to take into consideration, because the estimated efficacy expressed as an effect size of psilocybin, for example, in depression is so enormous that it really defies credulity, it defies believability. So part of this is clearly exaggerated, and I don't think we're doing anyone a service by not having a more precise estimate of the efficacy. So these things have to be sorted out.
Yeah, so it's although there can be some placebo effect, but this slide shows it's so much more robust across many patients, and also it happens quickly and stays there. Although this is a single treatment, again, it's not every day. It's a single treatment that seems to shake the brain in a new way, that some of the default network that has been arrested in the brain, always having negative thoughts or negative appreciation, not taking in any positive valences, is disrupted without having to have ECT, and then hopefully the patients would stay stable for a longer period of time afterwards.
Yeah, that's right. And so, we want a treatment everyone wants a treatment that's one and done. Well, it's not one and done. it's going to be one, and you'll probably need some more, but the longer that interval can be, the better. For ketamine, most studies report that after an effective acute treatment, unless you get ongoing treatment, relapse time to relapse occurs within 2 to 4 weeks. Suggestions are in the literature, but not confirmation, that psilocybin could be a little longer. Of course, we hope that's the case. One other point about the implementation, because we've done a randomized controlled trial with psilocybin that was our own study we did ourselves. I wanted to actually find out for myself, does this drug really work? What's the safety, etc.? And that is that we're interested in not only do they work rapidly, is the benefit lasting, but from an implementation perspective, our preference is to have a psychedelic that the patients are not tripping for 2, 4, 5, 6 hours. So in other words, we want it to be rapid acting, but short lasting with respect to its psychoactive effect, affecting level of consciousness, their emotions, their perceptions. And so there's everyone's heard of dimethyltryptamine, DMT. There's 5-MeO DMT, and these are being developed in different routes, including intranasal, where this is very short. It works in 5 to 10 minutes. The trip is done within 30 minutes. If you even need the trip, I don't know. So people are looking at more implementation aspects more these days. How can I give this medication in the real world where I don't have to watch the patient for 4 to 8 hours?
Yeah, so I see this also as a stepping stone. It's the unleashing of certain aspects in the brain and also the mechanisms of action of drugs that we've been having on the shelf and only tried by people who have substance abuse problems. This is not for substance abuse. This is salutary treatment, but hopefully in the next 5 to 10 years, we'll really separate some of the negative effects that this can happen with the unselective modulation of these receptors to be much more specific, as we've seen with other drugs too. Once we have really understood the mechanism, we can do much more here. Okay, so you've also compared effect sizes across these different treatments, and tell us about that, Robert.
This is a study we did. We tried to compare treatments on a level playing field, ketamine, esketamine, psilocybin. Look, the number needed to treat is in the single digits. These are thought to be clinically meaningful, and we are seeing highly relevant findings. So it's not just a p-value, it's not just a reduction in a depression score, but it is meaningful as indexed by NNT being a single digit. So I think that we don't know yet which one's better. These will be questions, of course, as part of comparative effectiveness of the near future, I hope, comparing ketamine, esketamine, and comparing the psychedelic, like, for example, psilocybin and depression would be very interesting. So that's what we found in our study, that they're all very effective.
Great. So let's talk about some other treatments that are in the making at the moment. What do you think about them? Last 2 minutes or so. So we have different mechanisms.
Yeah, to keep it brief, if you won't get into, we're looking at orexin modulators are being looked at, kappa opioid receptor modulators. People are looking at ion channels, potassium channels, KCNQ. It sounds like a rock station, a radio station. KCNQ. Modulators. This seems like alphabet soup. Well, what is all this? Well, what people are doing is they have mechanisms that are relevant to neuronal activity, neuronal function, using these molecular mechanisms to inform new therapeutics that can actually engage these systems. So it's a very hopeful time for psychiatry.
I fully agree. And maybe instead of going through all of the summaries, give us a clinical pearl, what you think our audience should take away from this, and then see whether we have time for 1 or 2 questions.
I think the most important takeaway is people should be familiar with esketamine's data and be familiar with ketamine as an intervention. I appreciate that not always available in all jurisdictions. I'm fully familiar with that. And I think it should be considered in the algorithm in the discussion with patients who are not adequately responding to treatment. The psychedelics, specifically the serotonin psychedelics, that's investigational, and we'll see where that goes. Our fingers are crossed that we have something in the next maybe year or so. But for now, they are investigational, and in the interim, stay tuned, because I think we are starting to enter into a new transformative time in psychiatry, and hopefully the transformation is not just clinically transformative, but it would be pretty cool to do this from a mechanistic perspective where we can modify their disease state.
Right, I totally agree, Roger. And I think what's really transformative is A, the speed and rapidity with which we now see an improvement in depression. Before we thought it takes weeks, this is days. And the next one is the effect size that is also double or more, even triple of that what we've seen with SSRIs. We have time for two questions. One is very apt to this discussion. We've talked about MDD. Well, depression occurs also in bipolar disorder. There have been individual studies. What do you think about these treatments for bipolar depression? And can they be given alone, or do you need a lid from above?
Well, I think when it comes to ketamine, esketamine, studies underway now in bipolar depression. We've done some work now with esketamine and ketamine in bipolar depression. We also have peer-reviewed funding supporting research with, for example, in bipolar depression. I'll give a quick summary. Patients with bipolar depression are benefiting. They don't have a higher risk of dissociation or psychosis or mania than people with MDDs. That's good news. We typically give it in combination with some treatments. There was some concern about giving it with lamotrigine, that may somehow mitigate the efficacy. But we do combine it with atypical antipsychotics, Christoph. That's quite common, quite frankly. There's a bit of fine detail as to what other drugs we may not consider. But yes, we do add it to existing regimens, usually antipsychotics.
And there is hope that this will also potentially be approved in bipolar depression.
Yes, absolutely. Yes, absolutely.
Now, another question is, when you add something to antidepressants, does it matter which one? So the question here is there any way to know the best antidepressant that you should give esketamine with?
No, we don't. I don't think that answer is known at this point in time. SSRIs, SNRIs, 40-oxytine, melatonergic antidepressants, we just don't know. Now, I should say, what do you not give it with? There was some concern about giving it with MAOIs, but that has been, I think, with experts in the area who do this a lot, they have found some cautious way to do it. I would say it's a general statement. We don't usually give MAOIs with ketamine, esketamine, but but some very experts in the area have been doing that. One final comment would be is that as it relates to ketamine, esketamine, some colleagues have asked me, well, can I transfer patients over to dextromethorphan, bupropion, to keep them well longer? I would say, well, like anything else, do what you want in life. But I think that's interesting. I think it's very coherent, but it's not been, I think it's a testable hypothesis. I just don't know the answer to that.
Yeah, and you mentioned also that esketamine actually now is approved as monotherapy. You don't need to augment an SSRI with it, and we'll see whether that is true for other agents. And just to remind the audience that that's a last question, that yes, esketamine is approved for suicidality. What about the psychedelics or zuranolone? Is there any effect on suicidality? Is it separate from depression? Is it the same, or do we just not know?
No data I've seen on zuranolone with respect to anti-suicide effects specifically, or independent of antidepressant effects. Psychedelics, there are some preliminary work showing some rapid alleviation of suicidality, but again, that is a very early signal. Now, to be careful. Some people may be susceptible to new onset suicidality, and that's been reported as well. We just can't not ignore that. And I think that has to be carefully considered as well. And patients who are at high risk of suicide are often not even entered into these clinical trials. So I think we have to just be a little careful. But for now, we are seeing, I would say, a relatively promising story, but maybe a reduction in suicidality with psilocybin and MDD. But that is a very early signal. That's got to be much more characterized.
Yeah, I think that's a cautionary tale. We know for people who are enriched for suicidality, esketamine does work, but we also have people who have a bad trip with some psychedelics, and there are clearly side effects of suicidality. And as you mentioned, the ones that are at highest risk might be excluded. So more time to actually evaluate this. So hopefully in a couple of years, we'll be back talking about this, maybe in this format or others. Roger, this was fantastic. You're such an encyclopedic knowledge person, and also apt in expressing this. I'm sure the audience took a lot out of this. So thank you so much for this great discussion.
Thanks for inviting me, and great discussion. Always enjoy it, and greetings to my colleagues.
Same here. So we want to also thank all of you to have joined this. MedLink Global brought this program to you. That was about the revolution in depression. We'll soon have another program coming up in order to inform clinical care. Thanks for your attention and see you soon. Bye, Robert.
Bye-bye.